Welcome to the first edition of Prime News from Amsterdam and the European Cancer Congress. I'm Dr. Lee Lokey with Prime Oncology. This year's European Cancer Congress has been an extremely busy and sometimes crowded meeting with approximately 18,000 healthcare professionals in attendance. Our goal with Prime News is to provide our viewers with news you can use from major international congresses as well as current oncology and hematology literature.
And I'm Dr. Janice Galleshaw and have joined Lee here in Amsterdam to hear presentations from the experts that may change the way you care for your patients in the near future. The theme of this Congress, as emphasized by the ECHO president, Dr. Cornelis van de Velde, is that multidisciplinary care really is the best way to provide quality patient care. With that in mind, we'll provide you a brief description of several compelling abstracts. All of these will be discussed in more detail in our upcoming October edition of our monthly newsletter, Prime Lines, which you can access on our website.
Thanks, Jan. As you know, there's a rapidly expanding portfolio of treatment options for HER2-positive breast cancer patients. At this ECC meeting, a very important abstract regarding the efficacy of TDM1, a drug-antibody conjugate, was presented. Tell us a little bit about this abstract.
Well, thanks, Lee. The study you're referring to is the TERESA trial, and it examined the use of TDM1 in patients with metastatic breast cancer who have progressed after having already previously been treated with not one but two anti-HER2 agents, both trastuzumab and lapatinib-containing combinations. This was a phase 3 trial, and it was compared single-agent TDM1 to the treatment of physician's choice. They randomized it in a 2-to-1 fashion, so twice as many patients received TDM1 as the physician's choice option. And they had a total of 600 patients. These were pretty bad prognosis patients. About 75% of them had visceral disease. And the results of this trial showed that those who received TDM1 had a near doubling of their progression-free survival. They also provided an interim overall analysis, and it had a similar trend as the progression-free survival, but it hasn't reached statistical significance at this time. In addition to that, the high-grade adverse events were actually higher in the treatment arm where the physicians were making the decision about use of which agent. So this is consistent with what we've seen previously in the Amelia trial. In that study, they were comparing the combination of lapatinib and capecitabine to TDM1, with TDM1 being superior as well. So I think we're rapidly gaining experience and insight into when we should be considering TDM1. And there's a large ongoing trial right now in the first-line setting called the Marianne trial that I'm eager to see what those results show us.
Yeah, this is the best of both worlds, efficacious and safe.
Yes, that's the way we like to do it. Now, Lee, there were two important trials examining the role of bevacizumab in ovarian cancer. Would you start by summarizing the findings from the Amelia trial for us?
Yes, Jan, these two trials both have the potential for impacting practice patterns. The first trial that you mentioned, the Aurelia trial, is a phase 3 trial of chemotherapy with or without bevacizumab for platinum-resistant ovarian cancer. Platinum resistance was defined in the classic way, being progression less than 6 months following completion of platinum-based treatment. Chemotherapy was, again, as in the TDM1 trial, physician's choice of either pegylated liposomal doxorubicin, topotecan, or weekly paclitaxel. The primary endpoint was progression-free survival. The secondary endpoint was overall survival. Crossover to bevacizumab was allowed for patients randomized to chemotherapy alone, and 40% of patients did cross over. What were the results? The primary endpoint was met in that the addition of bevacizumab to chemotherapy doubled progression-free survival. The best results were for weekly paclitaxel plus bevacizumab, which was quite interesting because traditionally the paclitaxel has been given every 3 weeks. Overall survival showed a 3-month improvement with the addition of bevacizumab, but the study was not powered for statistical significance of the overall survival. The discussant made the point that this was a clinically important and potentially practice-changing abstract. So very interesting results.
It certainly is. And the other study, the ICON 7, how would you summarize that one?
Yeah, this is also a phase 3 trial in 1,500 newly diagnosed ovarian cancer patients. This looked at the use of standard first-line chemotherapy with paclitaxel and carboplatin, plus or minus bevacizumab. The results here were that progression-free survival for the entire study population showed statistically significant prolongation with the addition of bevacizumab in the first-line setting. Overall survival for the entire study population showed no benefit. However, when you examined a pre-specified high-risk, poor prognosis group of patients, and these were stage 3 or 4, either not operated or suboptimally debulked, the addition of bevacizumab produced a significant improvement in both overall survival and progression-free survival. The discussant of this abstract said this was clearly practice-changing for this group of high-risk patients. So two exciting abstracts in ovarian cancer.
And it again, it's the same thing we keep hearing is we need to know how to better select our patients for any one of these targeted agents, it seems.
Yes.
Because when we look at the whole population, you don't see necessarily the benefit until you start, kind of going through and figuring out which subset will get the benefit.
Absolutely. Yeah. Well, that's our news from Amsterdam for now. Please give us your feedback on our blog. Thank you for watching.